Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Golden Valley Health Center for hosting today's session, Cholesterol Management Guidelines and Update with Dr. Craig Sadur. Real quickly, I am going to show you Dr. Sadur's disclosure slides and that he has nothing to disclose, and that is just our accreditation statement. Dr. Sadur, back to you.
Okay, thank you. Let me get this here. And for the current slideshow. Okay, thank you, Kristen, and welcome everyone. Good afternoon. Today we were going to go over cholesterol management guidelines, which came out a few years ago, but there's been updates that have been very exciting since then on a subject that we all know is so important. And we can do so many things to help our patients. So with that, this information, the guidelines came from a combination of the American Heart Association and the American College of Cardiology. And a lot of the updates since then came from the Endocrine Society regarding specific populations. So with today, the educational objectives to identify which patients would benefit from therapy for their dyslipidemia, to define different patient populations for stratification of their risk, and to apply the individualized treatment for optimal management of primary or secondary prevention of cardiovascular disease. The agenda will go over cases, review the non-pharmacological measures that have been shown to be helpful, risk stratification of different patient populations, talk about the online risk calculator, go over specific special populations, drug therapy, individualized management, and then the information resources that are helpful for us clinicians as well as for patients. So let's dive into it. Case number 1. We have a 20-year-old healthy Caucasian female. No history of diabetes mellitus, hypertension, dyslipidemia, tobacco, or family history of atherosclerotic cardiovascular disease. Her weight's normal. Her vital signs are normal. Unremarkable exam. So we get the feeling we're like, this is great. Young, healthy patient. What more could we hope for? And so the question is, what do we do? Well, it's good to do something. Counsel for a lifelong healthy lifestyle, which would include nutrition, weight control, exercise, being tobacco-free, stress management, and to measure lipids, ideally fasting if possible, because then you get a more accurate triglyceride level. And with the different lifestyle issues, nutrition is very important. There's been a lot of good information regarding plant-based. So this is something that comes from many sources. One is the American College of Lifestyle Medicine. And it's not an all or nothing. It's not like patients have to completely go plant-based, but to introduce it to patients, maybe one meal a week, try it. It's something that they could do and hopefully find out, hey, this is something that's very doable, tasty, healthy, not expensive. The American Heart Association, among others, has a Move More Together education for patients regarding exercise, which has been shown to be beneficial for lowering the risk of complications. The National Institute of Medicine has their national library on a variety of subjects, including tobacco cessation. And regarding stress management, this is just Dr. Herbert Benson, who fairly recently died after a long, distinguished career at Harvard. He started the Mind Body Medical Institute, wrote the relaxation response that's been helpful for clinicians and patients alike. Okay, with that background, case number 2, another young patient, a 25-year-old Asian male, and he has an increased abdominal girth. His blood pressure is 130/85, his fasting blood glucose 101, his high density lipoprotein cholesterol 39, his triglycerides 151. When I look at this, I look at those numbers and at first glance I go, not too bad. Okay. So with this young gentleman, what do we do? Well, again, lifelong healthy lifestyle, the cornerstone of treatment. And we're concerned about primary prevention of atherosclerotic cardiovascular disease because, he could very well have metabolic syndrome. And so with metabolic syndrome, we know he has an increased abdominal girth. So that can be indicative of adipose accumulation in the abdomen. And that's been the apple shape or android, although we can see it in women, but it's more common in men. And conversely, there's the pear shape, which is more gluteal rather than abdominal adiposity, and it's been called gynecoid, although we can see it in men, but it's more common in women. The concern is that increased abdominal adiposity is associated with increased risk for atherogenesis. And so we know this young man has an increased abdominal girth. So let's dive down a little further. With metabolic syndrome, you need 3 or more of these criteria to qualify for that diagnosis. And the waist size, 40 inches or more in men, 35 inches or more in women. But what happened since it was put out years ago was for Asians, and he is an Asian gentleman. We don't know his abdominal girth measurements, but he may have qualified for metabolic syndrome by having a 35 inches or more, which is less than non-Asians. Triglycerides 150 or greater, his was 151. So he's got at least that criteria. HDL cholesterol under 40, his was 39. So he's got at least that criteria. Women, the cutoff would be under 50. Blood pressure, he was 130/85, so he meets it right there with the triglycerides, the HDL, and the blood pressure. Maybe he meets it with waist, we don't know the measurement, but he's got metabolic syndrome, and then to really clinch it, he had a blood sugar that was slightly high. So the other thing just to keep in mind, if triglyceride is this level, or if they're on fibrates, HDL, or if they're on niacin or fibrates, blood pressure, or if they're on blood pressure medicines, and glucose, or if they're on glucose lowering meds. So he meets the criteria, as do so many people in our country. So the lifelong healthy lifestyle, start to assess it at age 20. We just went over 2 young patients. Primary prevention is key for someone with metabolic syndrome like our gentleman in case number 2. Okay, case number 3. We've got a 50-year-old Latina female, and it turns out there's different ethnic groups. Latino is one of them that has the metabolic, increased metabolic abnormalities that are leads-ins to the risk factors for cardiovascular disease. As it turns out, this woman has had a myocardial infarction. She's had a cerebrovascular accident. So she's, at a young age, has already suffered complications of atherogenesis. Her LDL cholesterol is 90. So again, at first glance, not too bad. So what do? Lifelong healthy lifestyle for all the non-pharmacologic measures that have been shown to be beneficial, to eliminate, whenever possible, or at least reduce risk factors. And for her, she has known disease. She's got multiple issues. So it's high intensity statin for her very high risk of atherosclerotic cardiovascular disease. She's already suffered 2 events, and certainly she's at risk for another one in the future. And in addition to statin, a lot of patients may need the addition of a non-statin treatment to get them a goal. And for someone like her, who's had cardiac events, cerebrovascular event, to consider lowering the LDL goal to under 70. So most people do not have anywhere near 70, so commonly folks would need pharmacologic therapy. So the LDL cholesterol in clinical atherosclerotic cardiovascular disease, to lower LDL with high-intensity statins, or at least maximally tolerated statins, to cut down that risk. And high-intensity statins include atorvastatin 40 to 80 milligrams once daily, or rosuvastatin 20 to 40 milligrams once daily. And the atherosclerotic cardiovascular disease basket includes cerebrovascular accident, which she suffered, transient ischemic accident, coronary artery disease with stable angina, acute coronary syndrome, arterial revascularization, peripheral arterial disease, aortic aneurysm. So a variety of manifestations of atherosclerotic cardiovascular disease. Patients can have one or multiple. So the statin intensities. We talked about the high intensity statin, and that's designed to lower the LDL cholesterol by at least 50%. Again, that's the atorvastatin 40 to 80 or rosuvastatin 20 to 40. For the moderate intensity, it's designed to lower the LDL 30 to 49%, and that's a lower dose of atorvastatin 10 to 20, rosuvastatin 5 to 10, simvastatin 20 to 40, lovastatin 40, and those are all once daily. But fluvastatin is another one that's 40 milligrams BID. And then the low intensity to lower LDL by under 30%, pravastatin 10 to 20 milligrams or lovastatin 20 milligrams once daily. And this would be something to consider if you have a patient, let's say you need to give that person statin, but the LDL is already 50. We don't see that often, but it's possible. That patient should be on statin to lower cholesterol. It also stabilize endothelial lining cells as well, and you can get away with a lower dose, but more people are going to need much higher doses. Keep in mind the CYP3A4 inhibitors, which are many drugs that patients may be on for a variety of reasons. So simvastatin, lovastatin, and to a lesser extent, atorvastatin are metabolized by the CYP3A4 system. And so if you have a patient who's on one of the CYP3A4 inhibitors, like let's say diltiazem, that increases the plasma level of statins, which increases the myopathy risk. So it's not a contraindication, but it's something to keep in mind. Rosuvastatin is metabolized by a different pathway, the cytochrome P450-2CN, and it really has a very limited role of the CYP3A4. So if you're looking purely at CYP3A4 inhibitor meds, you can go with something like rosuvastatin and not have to be as concerned. So for like that patient who was 50 years old, had suffered a myocardial infarction, had suffered cerebrovascular accident, she's at very high risk for atherosclerotic cardiovascular disease event in the future. So that's defined as patients with multiple atherosclerotic cardiovascular disease events. She had her myocardial infarction, she had her cerebrovascular accident. But rounding out the list, someone with acute coronary syndrome within the past year, peripheral arterial disease with an ankle brachial index, which can be measured in the clinic, of under 0.85, someone who suffered peripheral arterial disease, amputation, or past revascularization. So these high-risk multiple events, 2 or more, or one major event, let's say a myocardial infarction with high-risk conditions. What are those high-risk conditions? Defined as age greater than 64 years, familial hypercholesterolemia, which is pretty common, past coronary artery bypass graft, diabetes mellitus, hypertension, chronic kidney disease with an estimated glomerular filtration rate of under 60. So these are the high-risk conditions that coupling with the high-risk event puts them at a very high risk for a future event with atherosclerotic cardiovascular disease. So in terms of the future for these patients, lower the threshold of LDL targeting for under 70. So it's roll up the sleeves, be aggressive, and really get that LDL cholesterol down. A lot of patients will need multiple drugs. So statin is the cornerstone treatment, but it wouldn't be a surprise to try and get that a level of LDL below 70 by adding a second drug, and one that's commonly been around for years is ezetimibe. Okay, let's do another case. We've got a 30-year-old Pacific Islander male. Now, as the patient Latino, there are different ethnic groups. Pacific Islanders are another one for increased risk of metabolic abnormalities that can increase the risk of atherosclerotic cardiovascular disease. Turns out this patient's father had a myocardial infarction, and a maternal uncle had a history of angina. So he's got the double whammy. He's got it on both sides of his family, strong genetic concern. And he's got an LDL that's 190. That's very high. So with that, he hasn't had any known atherosclerotic cardiovascular disease, but we're concerned about his genetics. We're concerned about his cholesterol. So what do? We're talking to him about his diet history and medicine. So we want to see if there's a secondary, if not cause, at least an aggravating condition that would raise his LDL cholesterol. And one that you hate to miss is hypothyroidism, because hypothyroidism can frequently worsen lipids. Nephrosis. So in addition to getting the estimated GFR, doing a urine dipstick, seeing if there's a lot of protein. And cholestatic liver disease, in particular cholestatic in terms of liver disease. Lifelong healthy lifestyle, and eliminate, whenever possible, or at least try and reduce cardiovascular risk factors, and a high-intensity statin. He's got a 190 LDL cholesterol. And again, the high-intensity statins are designed to lower the levels by at least 50%. He's going to need a lot. And the goal is to get that LDL below 100 for a patient with primary prevention, but a concerning family history and a concerning LDL cholesterol. And in addition to the statin, he may need a secondary drug. It wouldn't be a surprise if he did. So severe primary hypercholesterolemia. That's what he's got. He's got an LDL cholesterol of 190 or higher. And it's very common for these folks to have heterozygous familial hypercholesterolemia. So it pays to get first-degree relatives, that would be parents, siblings, and children's, get their lipid panel, because they may have it without even being aware. And the number that always amazes me is there's a 20-fold greater risk of a cardiovascular event in this fellow who's got an LDL cholesterol of 190 than if his LDL was 130. 20-fold increased risk. So getting that level down, you will have done a great service to lower the risk of future events. And to treat with the statins, the primary goal is to drop that LDL cholesterol by at least 50%. Secondary goal will be try and get that LDL below 100. And if it's still above 100, consider adding ezetimibe. Okay, case number 5. So here is a 42-year-old Black female with type 2 diabetes. And again, as far as ethnic groups, Black patients have increased risk of metabolic abnormalities that can lead to atherosclerotic cardiovascular disease. One of the metabolic abnormalities that we're concerned about is type 2 diabetes, which is increased. But the good news for her is there's no family history of atherosclerotic cardiovascular disease. She's not a smoker. Her blood pressure is normal. Her weight's normal, and her exams are unremarkable. So with that, what do? Well, lifelong healthy lifestyle, again, always important to consider before automatically jumping to meds. Continue to monitor for risk factors. Hopefully she'll never get hypertensive, but it's not uncommon for patients later in life to get it. And hopefully she'll never smoke and all the other potential risk factors. Optimize her diabetes control. So glycemic control has been shown to have multiple benefits, particularly for microvascular complications. That'd be the nephropathy and the retinopathy. But it has been shown to be beneficial for macrovascular, which would be coronary artery disease and cerebrovascular disease. Check the lipids, preferably fasting, so we can see what her triglycerides are. People with diabetes can, especially when their diabetes is suboptimally controlled, to have significant hypertriglyceridemia. And there's enough people running around with genetic abnormalities with hypertriglyceridemia. It's always nice to know sooner rather than later. And if the LDL 70 or greater for this patient who's relatively young, has type 2 diabetes without other risk factors, try and get that LDL below 70. And that would commonly call for at least a moderate intensity statin treatment. Okay, so case 6, a little bit of a variation. He's slightly older than the previous patient, 60-year-old black male. Again, we're concerned about the increased risk of complications just simply due to his ethnicity. He's got type 2 diabetes. Unlike the patient who didn't have other risk factors, he's a smoker. He's hypertensive. He's got a family history of atherosclerotic cardiovascular disease. So when you sort of think, take a step back and look at the multiple risk factors, it's a concern. It's a call for getting even more aggressive to try and help this gentleman. His weight is normal, and his physical exam is otherwise unremarkable. So what do we do? Sounds familiar, but again, healthy lifestyle with tobacco, nutrition, weight, stress, etc. Tobacco cessation, counseling, very important. If he did one thing, although I hope he does more than one thing, but if he did one thing, maybe the most important is stopping tobacco. That would be huge for him. It's never too late. Hypertension control, vitally important. It was a number of years ago, studies showed a drop in cerebrovascular accident incidents, and it was thought to be multifactorial, but probably maybe more than anything else was hypertension control. And in the old days, controlling hypertension was really challenging because there were so few meds and they were not well tolerated. Now, fortunately, we've got many meds, and vast majority of patients have no problems tolerating them. So getting blood pressure down is key. Optimizing diabetes control, like we talked about with the previous patient, and checking lipids, again, preferably fasting, and consider a high intensity statin. He's got multiple risk factors. We're concerned. We want to work on everything, and one of them is getting his LDL down. So for the last two patients, they both had diabetes. And if we're looking at age 40 to 75, so early middle age to somewhat older, if the LDL 70 or higher, then to give a moderate intensity statin, and depending on the levels, maybe increase it. So we're talking about diabetes, age 40 to 75, primary prevention, aggressively trying to get that LDL cholesterol below 70. And a moderate intensity statin, as a review, lovastatin 40, pravastatin 40, simvastatin 40, atorvastatin 10 to 20, rosuvastatin 5 to 10, pitavastatin 4 milligrams. So all kinds of options. And if you have diabetes and multiple risk factors, like the gentleman we presented just before this, or age 50 to 75 as he is, it'd be reasonable to give a high intensity statin to decrease the LDL by at least 50%. And again, you're going to give the statin, and then you're going to measure the LDL, and we'll get into that in a little bit. So the LDL goals, if you have diabetes and known atherosclerotic cardiovascular disease, these two patients didn't, but let's say you have a third patient who has suffered a complication, let's say has known coronary artery disease, then the high intensity statin is the go-to to decrease that LDL by at least 50% from baseline. And we're shooting for an LDL goal of less than 55. So in this decades that we've had statin, we've seen the LDL goal drop lower, lower, and lower. So we're talking about a concerning population. Diabetes and known atherosclerotic cardiovascular disease. It's really trying to help these folks by getting their LDL cholesterols aggressively treated. And commonly, you'll need a second drug, ezetimibe, which has been around for decades, is relatively expensive. There's also the PCSK9 inhibitors. That's recommended if goal is not met on maximally tolerated statin treatment. Fortunately, most patients, you don't need to go to that, but if need be, it's something that's very well tolerated. And again, this comes out every year in the standards of care in diabetes, and strong emphasis on trying to reduce future complications. So diabetes type 2 and diabetic retinopathy. Why are we talking about this in a dyslipidemia presentation? Well, turns out to consider fibrates in addition to statins to reduce retinopathy progression regardless of triglyceride levels. And again, these are some of the newer developments. So you've got a patient with diabetes. He or she has triglyceride of 120. We go, great, but has diabetic retinopathy, and it could be really mild, like diabetic background retinopathy. But the studies have shown giving a fibrate in addition to statin reduces that retinopathy progression. And if you're going to do it, the preferred fibrate is fenofibrate because in combination with a statin, that's the recommended one. So diabetes mellitus type 1 and statin consideration irrespective of the cardiovascular risk score, and we're going to get into the risk score later. If you're 40 years or older with type 1, if you've had diabetes duration for more than 20 years, so a lot of times they've got it during childhood, they've had more than 20 years, even at an early age, like in the 30s. Microvascular complications, again, it could be mild retinopathy, it could be some albuminuria, obesity, and most type 1s are not, but there are some, especially where you've had to intensify insulin dosing. A high triglyceride and a low HDL, which is the atherogenic lipoprotein combination we so commonly see, particularly in type 2, but you can also see it in type 1. You got the high triglyceride, low HDL, so that's a smaller, denser, more atherogenic lipoprotein. So for type 1s who meet any of these criteria, consider statins. So you may be looking at a young patient who you're concerned about because the clock's already ticking for developing complications. So with type 1, LDL cholesterol is the primary target. Consider lowering it below 70. So again, that's going to take meds in addition to lifestyle. Statins, as a caveat, should not be used in women who are either pregnant or trying to become pregnant. So just to consider for type 1s. For type 1s and chronic kidney disease, which is a common complication, even stage 1, but up to stage 4, consider statin irrespective of the cardiovascular risk score. When you have type 1 and you have kidney disease, you're on a pathway for atherogenic problems, heart, cerebrovascular, peripheral arterial. So again, it's treating sooner rather than later. For type 1, consider statin treatment if the LDL is greater than 70. When selecting a statin, consider renal clearance. And various statins have some at least partial clearance, but others are mainly cleared by the liver, such as atorvastatin. All statins require dose adjustments in chronic kidney disease, except atorvastatin and fluvastatin. So if you do atorvastatin, you can a lot of times get, if you need higher intensity, you can do it for patients with some renal issues. Ezetimibe can be added to a statin to lower the LDL further. No dose adjustment is needed in chronic kidney disease. So this is from Dr. Lisa Tannick of the Endocrine Society, talked about women in pregnancy. Statins should be discontinued 1 to 2 months prior to a pregnancy, ideally. But if the patient was found to be pregnant, discontinue the statin right away. And women of reproductive age on a statin should be counseled regarding reliable contraception. Okay, case number 7. A 50-year-old Native American female. So again, Native American, like Latino, like Pacific Islanders, like Blacks, have increased incidence of metabolic abnormalities that can lead to atherosclerotic cardiovascular disease. She doesn't have a family history of atherosclerotic cardiovascular disease. She's not a smoker. Her blood pressure is normal. She doesn't have diabetes. And she has no history of dyslipidemia. So we're feeling better about things. But she hasn't been tested for years. So we don't know what her lipids are. So what do? Well, lifestyle for her the rest of her life. Continue to monitor for risk factors. Hopefully no one in the family will get atherosclerotic cardiovascular disease, but just to keep in mind. Check the lipids to see if her LDL 70 or higher, and then do the calculation of a 10-year atherosclerotic cardiovascular risk. If it's 7.5% or higher, even though she's not had anything that would otherwise tilt the scale toward treatment, if she scores that high, then she's a candidate for moderate intensity statin treatment. So if you're age 40 to 75, so early middle age to older without diabetes, it's a shared discussion because Cardiovascular disease is the number one cause of mortality in our country. So share discussion and review the risk factors: smoking, hypertension, LDL cholesterol, A1C, and the calculated 10-year atherosclerotic cardiovascular disease risk. So we've got the tool, and it's free. It's on the internet. And it's something that is helpful for clinicians, but also patients seeing it can find out what their risks are. And if there's a 10-year risk that's 7.5% or greater, so that means in the next 10 years, the patient has a 7.5% or higher risk of a new cardiovascular event, it's worth a statin consideration. And here's the risk estimator. So this, again, comes from American College of Cardiology. You put in the patient's age, the gender, the race. Right now, it's pretty limited to white, Black, and other. Hopefully, with data, this will be updated, but right now, these are the main areas that are used. Systolic blood pressure, diastolic blood pressure, total cholesterol, HDL, LDL. You notice you don't need the triglyceride, but again, it's always nice to know what the true triglyceride is. History of diabetes, yes, no. Smoker, current, former, never. On hypertensive, yes, no. On statin, yes, no. On aspirin, yes, no. So pretty basic information, minimal history, blood pressure, lipids, and you can get the estimated risk. Okay, case number 8, 52-year-old Indian male. No family history of atherosclerotic cardiovascular disease. Psoriasis, okay. For us non-dermatologists, you go, all right, psoriasis, pretty common. Estimated GFR of 50, so he's got some renal insufficiency. So what do? Well, you do the lifelong healthy lifestyle and continue risk factor monitoring and check the lipids, preferably fasting, and do the calculation to see if he's 7.5% higher for a cardiovascular event in the next 10 years via consider statin treatment. There's more. So what's happened over the last few years, in addition to the main risk factors, hypertension, diabetes, et cetera, there's atherosclerotic cardiovascular disease risk-enhancing factors. And what are these? Well, family history of premature atherosclerotic cardiovascular disease. So, you know, we've seen it. We saw with that earlier patient. You know, this is a patient who's got a family history and maybe on both sides. LDL persistently 160 or higher. So not in the automatic familial hypercholesterolemia range, but it's possible patients could have familial hypercholesterolemia with an LDL not as high, but still 160 or higher. Metabolic syndrome, like you saw in that young patient earlier. Chronic kidney disease, even mild. For women who have had a history of preeclampsia or premature menopause, which is defined as under 40 years of age, this is a risk-enhancing factor. Chronic inflammatory disease, so rheumatoid arthritis, HIV, and there's the psoriasis, because I wouldn't have thought of that, but it's part of the mix in terms of risk-enhancing factors. High-risk ethnic group, and he is Indian, and that's South Asian, and that's considered one of the high-risk ethnic groups. So that plays a role. So kind of adding things up, you get this picture of atherosclerotic cardiovascular disease, even in a non-smoker, normotensive, non-diabetic patient. You look at these and you go, you know, there's sort of this milieu of concern. And if you have a triglyceride 175 or higher, so again, not alarmingly high, but persistently mildly elevated, you start to think this is a patient at risk. So this again was put out by and if you want to look at one slide just to sort of characterize the guidelines, it's right here. So in other words, focusing on 4 major benefit groups, those with known clinical atherosclerotic cardiovascular disease, as we can imagine, myocardial infarction, CVA, these are people we definitely don't want to get another event. We're talking about secondary prevention. Those with the LDL 190 or higher, even if you're young and healthy and doing great and nothing else seems to be going on, this is a concern. So you want to focus on this. The third group, people with diabetes age 40 to 75 and an LDL not impressively high, but 70 or higher. They've had diabetes probably for a fair number of years. They've got an LDL that's enough of a concern. We're concerned with them. And for those who have an LDL of at least 70 and a 10-year risk on the calculated tool of 7.5% or higher, these are the groups you want to hone in on treatment. These are the ones that have been shown to be very responsive to treatment by lowering the risk in the future. So LDL levels are key to follow, and additional therapy in addition to statin, you may need ezetimibe, and in some cases, considering a PCSK9 inhibitor. Secondary prevention, if you're under 75 and you have clinical atherosclerotic cardiovascular disease, as we could picture, a high-intensity statin. If you're very high risk for it, so in other words, we're talking primary prevention, and the LDL 70 or higher on maximum tolerated statin, consider adding a second drug. Here's some specifics. The PCSK9 inhibitor is only recommended for very high risk. It's very expensive, but there are insurance plans, Medicaid, depending on location, where you've tried everything else, you still need to bring it down, and this could be something that is okayed. Age 75 or greater, atherosclerotic cardiovascular disease, it's not, the guidelines don't call for let's go in and treat, but we've seen that. If you have a patient who's already taken and doing well, or wants to take it, or is youthful and looks like could go another many years of life expectancy, it's not wrong to treat, and it's always individual clinical judgment. Okay, so high triglycerides. If you have high triglycerides of fasting greater than 500, that means you're probably running postprandial much of the day, well above 800 to 1,000. So you're talking about circulating chylomicronemia, which puts the patient at the dreaded complication risk of pancreatitis. So that's why you're starting to think of treatment, pharmacologic therapy. Diet's key, but these patients are going to need some treatment. There's omega-3 fatty acids for triglycerides, and for patients on statins who have moderate elevated triglycerides of greater than 150 and who either have known atherosclerotic cardiovascular disease or diabetes plus 2 additional risk factors, adding icosapent ethyl, which there's DHA and EPA, but this is pure EPA, which has been found to be more beneficial. Consider adding the omega-3 fatty acids to these patients to reduce cardiovascular disease risk in the future. It's hard to get that kind of level of over the counter. It can be done, but there are prescription brands of 1 gram Lavazza, Vascepa, Epanova, and the dose can be 2 grams BID. If EPA is not available or accessible, consider a fibrate. And again, you're adding to a statin, so the fibrate of choice is fenofibrate. So omega-3 fatty acids in cardiovascular disease, studies, observation, tend to show correlations between higher fish consumption and lower risk. It's interesting, there were native Canadians up in the Hudson Bay area who have high blubber intake with their fish, and they had very low cardiovascular disease until there was the Western diet introduced with fast food and others, and then they started to have increased risk. But higher fish consumption has been shown to be helpful. They've done some random controlled studies, randomized controlled studies. Haven't been impressive, but there was one randomized control study, the REDUCE-IT, that showed significant protective effects with the icosapent ethyl. So there is some literature. So adults with endocrine disorders beyond diabetes, it's recommended to do a lipid panel for the assessment of triglyceride levels and for calculating LDL cholesterol. And lipid disorders such as thyroid function, if you're hyperthyroid actually works in a patient's favor in terms of dyslipidemia. Lipid panels tend to get better with hyperthyroidism, but there's all the other complications of hyperthyroidism. You don't want to leave people hyperthyroid. But once you treat the patient, who's now euthyroid, reevaluate the lipids because they are more realistic for what the patient's true metabolism is and may put the patient into a category of needing treatment. If there's overt hypothyroidism, meaning that TSH is greater than 10, consider treating the hyperlipidemia once the patient's euthyroid. In other words, part of the metabolic derangement with the dyslipidemia is the overt hypothyroidism. Treat the hypothyroidism and then see what the fasting lipids are. Subclinical hypothyroidism, defined as TSH under 10, if there's associated hyperlipidemia, consider L-thyroxine therapy to decrease the lipoprotein levels. The caveat is, if the TSH is under 10, give a small dose because you don't want to over-replace, because then you have iatrogenic hyperthyroidism and you can cause problems. So, we're talking like 0.025 milligrams or 25 micrograms of L-thyroxine. PCOS, polycystic ovary syndrome, and lipids. PCOS, very common. Check the fasting lipids to assess cardiovascular risk. Hypertriglyceridemia is the most common lipid abnormality in these patients. So a lot of women with PCOS have concerning dyslipidemia, as well as other insulin sensitivity issues such as type 2 diabetes and hypertension. Suggested steps in the risk assessment. So if you have a patient who has known atherosclerotic cardiovascular disease or longstanding diabetes, you're done. You don't have to do any more. I wonder why, if this patient should be on treatment. The patient does need treatment. But if not, then calculate the 10-year risk and assess for the individual additional risk-enhancing factors. Now, if you have a patient with persistent Cushing syndrome, Cushing disease on therapy, there's some rarer ones, growth hormone deficiency, acromegaly, hypothyroidism, not rare. But if you have a patient with Cushing syndrome, and the most common cause is someone's going to be on glucocorticoid therapy, which is given for a variety of reasons, asthma, rheumatoid arthritis, et cetera. Then, think about risk-enhancing factors. And one caveat, if you have a patient who looks like he or she is on prednisone, but not, you may have a patient with Cushing's syndrome. And then reach out to MAVEN Project endocrinologists. We'd be glad to help you with the evaluation. In the borderline to intermediate, the 10-year risk in the 5 to almost 20%, there's a coronary artery calcium score that's been recommended, but most of the time you won't need it. It's going to be pretty clear. And then clinician-patient risk discussion. There's lifetime risk that you can do with a calculation. Because again, you're talking about chronic therapy to help this chronic metabolic problem and to go over with the patient. So steroid abuse. There are a fair number of patients, some women, but almost all are men who abuse steroids. If you have someone with an HDL under 30, especially without hypertriglyceridemia, think about the possibility of anabolic steroid abuse. Super physiologic doses of androgens that are given through a variety of ways, not just testosterone, but these designer androgens will reduce HDL and increase the risk of future cardiovascular disease. Transgender with lipids, important consideration. In trans women and trans men with past or current gender-affirming hormone therapy, assess the cardiovascular risk and use the calculator and be conservative. That's the recommendation. Use the male category for trans women because there's not a specific trans women category or trans man category. So we've got to use with what we've got. So for trans women, use the male category. And for trans men, it's recommended to use the category for cis women and cis men. See which one's higher. And if the criteria is met, go ahead and treat. If there's greater than a 10% cardiovascular risk, then consider aspirin use to prevent cardiovascular disease. And that's the U.S. Preventive Services Task Force. Okay, so you're treating patients. You want to monitor, see what the response is. So repeat the lipids 4 to 12 weeks. I just do in 8 weeks, 2 months. I like to think simply and just 2 months, start lipids, check what it is. That's either starting statin or adjusting the dose, and then repeat it at least every year just to see where you are. And then for atherosclerotic cardiovascular patients at very high risk, have a low threshold for adding a non-statin drug to get that level down to 69 or less. Non-statin meds, we've talked about ezetimibe, been around for decades, well tolerated, inexpensive. Bile acid sequestrants, been around many decades, and there's a literature pre-statin that they do help. Thing to be aware of, some patients get gastrointestinal symptoms, bloating, constipation. So sometimes people need fiber in addition, decreased drug absorption. So if you're on warfarin or L-thyroxine and some of the others, to time it so that there's no interference with gut absorption. Bempedoic acid is expensive but effective in lowering the synthesis of cholesterol. So it's an option in patients who may have trouble with statins. Inclisiran, very effective, very expensive. And the PCSK9 inhibitors, again, very effective, very expensive. But again, if you've gone through everything, and for that small minority of patients who you need a different category of drugs, there's options. So in conclusion, atherosclerotic cardiovascular disease risks drop through lipid management. It really does work. The treatment significantly improves the outcome. Candidates for treatment of blood cholesterol, their blood cholesterol to drop the atherosclerotic cardiovascular disease risk, people who have known disease, so we're trying to do secondary prevention, people with very high LDLs, 190 or higher, people with diabetes ages 40 to 75, ages 40 to 75 without diabetes or atherosclerotic cardiovascular disease, but with a 10-year calculated risk of 7.5% or higher. Special lipid treatment considerations for people with diabetes and retinopathy. Again, we're talking fibrate if they have any kind of retinopathy. Type 1, age, disease duration, microvascular disease, obesity, metabolic syndrome, chronic kidney disease, hypertriglyceridemia, folks, thyroid dysfunction, something to be aware of that will affect lipid levels. PCOS, very common to have insulin insensitivity, including dyslipidemia, steroid abuse, transgender. So in summary, lipid abnormalities, very common. Screening, very important. Lifestyle, cornerstone of treatment. Treatment is individualized. Medication, usually well tolerated. So with endocrine disorders, take a lipid panel for optimally fasting. Treat the folks with type 2 and other cardiovascular risk factors with a statin in addition to lifestyle modification. Consider a statin regardless of the cardiovascular risk that you're calculating in a type 1 who's 40 years or older. Hypothyroidism can affect the treatment. Reevaluate the lipids once the patient's biochemically euthyroid. Consider a statin in addition to lifestyle modifications in patients with Cushing syndrome. Most common is going to be a patient who has to be on glucocorticoid therapy. Evaluate and treat lipids and other cardiovascular risk factors in women who enter menopause early, at least before 45, but especially before 40, as well as a history of preeclampsia. So in conclusion, atherosclerotic cardiovascular disease risks drop through lipid management. Treatment significantly improves outcome. You can do so much to help your patients. Resources, if you want to dig deeper into the guidelines, there it is. Endocrine Society came up with different guidelines for different populations. There's the American Diabetes Association, American Heart Association. There's lots of reading material for patients. There's the risk calculators, free of charge. Patient resources in the Endocrine Society, excuse me, patient engagement, learn your lipids. You can get it free of charge. American Heart Association, Move More Together. NIH tobacco cessation. And for diet, nutrition, there's the 4-leaf guide to vibrant health, written by primary care doctor and I think a nutritionist. Excuse me. There's forks over knives. has the book, has a very fascinating documentary, American College of Lifestyle Medicine, and up to date has a section on stress that patients can have. Excuse me. So special appreciation to Kristen, who you saw at the top of the hour and we'll see again, our MAVEN Project program coordinator, Jill Einstein, our physician senior director of physician engagement, Shirley Severe Talon, Jonathan Lewis, our IT gurus. If these folks don't do the things, these presentations don't take place. I mean, they do the heavy lifting and they give the easier part to us. So I appreciate all of them. And so with that, let me open it up to questions.
Thank you so much, Dr. Sadur. First, you're going to give me a bigger head, but thank you so much. We have a few questions. The first question is, there seems to be a lot of negative reputation with statins. How would you treat such patients? Would ezetimibe or fenofibrate be an option as monotherapy to help lower LDL?
Yes, there is the internet, as we've seen, has saints and sinners, and there's some wonderful educational information, and there's a lot of disinformation. So with statins, as with any medicine, there is potential side effect, and the most common is muscle, and the most common one of muscle is myalgias. So the vast majority of people on statins do fine. There's a small percentage who get muscle issues, and very, very, very rare is rhabdomyolysis. So if you have 1,000 patients on statin, maybe at the most, you get 3 where there's concerning issue. It's more like 1. So yes, they're there. Yes, patients should know about it. And if you have a patient who develops some muscle symptoms, take it seriously like we all do. If need be, if there's severe, you can check a CK level. But for the most part, stopping the statin, letting the muscle symptoms resolve, and then you've got a choice. You can restart onto another statin, and for whatever reason, there are patients who are intolerant of one statin, but they can tolerate another. Pravastatin is one that has a different metabolic pathway, and there are patients who may not be able to tolerate a couple of statins, and they can do well with that. So there's almost always a statin the patient can tolerate and do well. If you find you still can't do it, then you could go to less than daily treatment. And let's say atorvastatin. You could start with once a week. And if the patient's doing well, go to twice a week, non-consecutive days. Patient's doing well, go 3 times a week. And when you reach the dose that's not well tolerated, then dial back to the highest tolerable dose. So again, we're talking about a small percentage of the vast majority of patients, but it does exist. It's rare to have a patient that can't tolerate any statin at any dose. And that does happen, but it's very, very rare. And then you can go to alternative. Ezetimibe, like I mentioned, bempedoic acid, there was a study not too long ago showing really good results. It's just that the statins have the more robust data to show their benefit.
Great. We have about 6 more questions, so I'm very excited. Next one. When and how would you treat someone with low HDL and LDL at target, and conversely, someone with very high HDL and LDL at target?
Okay, so the HDL, the quote, good cholesterol, is helpful. And in the previous days, they would look at ratios like HDL to LDL or HDL to total cholesterol. People have moved away from that, and they've used predominantly LDL.